Okay, so this week we're covering urinary system and venipuncture. Okay, so as usual, we will start with some anatomy first. Okay, so the urinary system consists of two kidneys. Okay, as you can see here, two ureters, one urinary bladder, and the urethra. Okay, so we're able to X-ray. We're not able to see the internal organs, but that's what a KUB stands for: kidneys, ureters, and bladder. So we want to make sure that all of that is included on a KUB. Now we won't be able to see really the kidneys, the ureters, or the bladder without contrast medium. Okay, and so like I've mentioned before, the right kidney is going to be lower than the left kidney, usually due to the liver, right? The liver is going to push it down, causing it to become lower than the left side, than the left kidney. Okay. Each kidney is going to be connected to a ureter and then down into the urinary bladder. Okay. And so as it says here and it's starred, the fatty capsule around the kidneys, that's why sometimes we can visualize the outline of the kidneys on KUBs because of the fatty capsule around the kidney. So because of that, we can sometimes visualize kidneys on plain abdominal radiographs. Okay, so the presence of the fatty capsule around the kidneys permits radiographic visualization of the kidneys on plain abdominal radiographs. Okay, suprarenal or adrenal glands are going to be in the superior portion of the kidneys. Okay, so this is a posterior view. So this is demonstrating relationship of kidneys to the posterior ribs, as well as the liver and the spleen. It is important that you are aware of where your organs lie in relation to other organs, okay? So they're gonna be, the posteriorly placed kidneys lie in the upper posterior abdomen, okay, on either side of the vertebral column. So in the posterior abdomen, okay, not anteriorly, they're closer to the spine, okay? The right kidney is going to be located behind the lower border of the liver. Remember, that's what causes it to be pushed down. And the left kidney is going to be positioned inferior to the lower border of the spleen. Here we have a lateral view. We see the kidney, ureters going into the kind of posterior aspect, posterolateral aspect of the bladder. Okay, so the kidneys and the ureters are retroperitoneal structures, and infraperitoneal structures are going to be the organs that are in the pelvic area. So the distal ureters, the urinary bladder, and the urethra. Now this slide here is very important because it's showing how they are positioned, the kidneys inside our abdomen. So the kidneys are 4 to 5 inches long, okay, 2 to 3 inches wide and 1 inch thick. Again, left kidney is it's a little longer, okay, but narrower than the right. Okay, so as you can see, this angulation that's going on here, we have the mid-sagittal plane, and then the kidneys are going to be at a 20-degree angle from that mid-sagittal plane. Okay, so they kind of go medial and then out, medial to lateral, right? And this is due to the longitudinal plane of the psoas muscles. So psoas muscles are here, they come out at an angle, right, at a 20-degree angle, and that is why the kidneys also follow along the long aspect of the psoas muscle. Okay, so that's what's causing it to have that 20-degree angulation from mid-sagittal plane, the psoas muscles. And so they also have a backward position as well. So yes, we have that 20-degree from mid-sagittal plane, but they also go back. Okay, so the kidneys rotate backward within the retroperitoneal space. Okay, so the medial border of each kidney is going to be more anterior than the lateral border. So it goes anterior and then, well, anterior and then posterior. Okay, medial aspect, more anterior, lateral aspect, more posterior. So they roll backwards. And that's going to be important when it comes down to positioning, right? If we want to make the, let's say, for example, the right kidney parallel to the image receptor, sorry, the left, we would have to do this, right? That's going to make it parallel to the image receptor, okay? If we wanted to get the opposite side parallel to the image receptor, we have to rotate those 30 degrees, okay, to make the upside kidney parallel to the image receptor, okay? Otherwise, you're not visualizing the kidneys in a true AP view because they're angled backwards. Kidney location, you will see questions on kidney location on your quizzes, assignments. So the kidneys are located halfway between the xiphoid process, which is up here, and the iliac crest, somewhere between those two anatomical landmarks, okay? So between T11, T12, and L3 specifically, okay? Because the iliac crest is located at L4, L5, but kidneys will be between T11 and L3. Okay, T11, T12, and L3. Nephrotosis is also called floating kidney, and it's a downward displacement or a dropping of a kidney. So when a kidney is really low, okay, abnormally low, it's called nephrotosis or floating kidney or renal ptosis. The function of the urinary system, important that we know this very important function. So primary function of the urinary system is the production of urine and its elimination from the body. Okay, so very important, removes nitrogenous waste, regulates water levels in the body, regulates acid, base, and electrolyte levels. Okay, buildup of this waste. So if your urinary system is not functioning correctly, then it can result into a clinical condition termed uremia and can cause renal dysfunction. Okay. We can skip over this. So this is important that you will have to identify this structure. Okay. So the different structures or microscopic structures of the kidney. So we have the ureter, we have the renal pelvis, then we have the major calyx, okay? We have these individual renal pyramids, okay? 8 to 18 renal pyramids. We have the renal papilla, okay, which is that corner there. In between each renal pyramid or medulla, we have the renal columns. In between each renal pyramid, we have the renal columns. Okay, and then we have the minor calyx. So major calyx, then minor calyx, then into the renal pyramids. Okay. The nephron is the structural and functional unit of the kidney. Okay. These are the components of a nephron and the collecting ducts. Okay. Urine production, okay, about 2.5 liters per day, okay, into the bloodstream, then it gets filtrated, 99% gets absorbed, and then comes out is eliminated as urine. Okay, this is a very important slide. So the 3 different points of constriction of the ureters, okay? So we have 3 different points of constriction. So the uteral pelvic junction, okay, it's called uteral pelvic because it's going to go through the renal pelvis, okay? It's going to go over the renal pelvis. So that's the uteral pelvic junction, okay? So let's go back, the renal pelvis again, you guys, over here. Right here. So this is the first area of constriction in the ureter. Okay, starts over here. It's the uteral pelvic junction. Okay, number 2 is the pelvic brim. Okay, so that's where the iliac blood vessels cross over the ureters. Okay, or the ureters are going to cross over the iliac blood vessels, which are these in red and blue. Okay, so that's going to cause a constriction. And then 3 is the uteral vesicle junction. Okay, so that's where the ureters join the bladder. So these are the 3 points of constriction. Those are important that you're able to identify. Okay. So inside the urinary bladder, we also have rugae. Okay, so where do we have rugae? We also have rugae in the stomach, right? So they're the mucosal folds, okay, inside the bladder. Males have a prostate gland, right? Only males, and it's going to be distal to the urinary bladder. Here we have an image of an IVU, intravenous urogram, demonstrating kidneys, ureters, and bladder down here. Okay, so notice we are clipping the top of the kidneys, so we're centered a little too low. Okay, we want to include the top of the kidneys as well. Bladder functions and terminology, definitely review these. Male pelvic organs in relation to the bladder. Okay, so again, bladder, then we have the prostate gland, and through it is the urethra, sorry, goes through the prostate gland. Female pelvic organs in relation to the bladder. So the bladder is inferior to the uterus. Okay. Here we have anatomy of the kidney, right? And the ducts and things like that. This is anatomy of the bladder and the urethra, a male urethra. Okay, moving on to venipuncture. Okay, so venipuncture is the percutaneous puncture of a vein for withdrawal of blood or injection of solution, such as contrast media. So we're going to be using venipuncture for injection of contrast media for these urinary exams. So we have bolus injections. We also have drip infusions. Okay, so bolus injections are going to be a larger amount of contrast media given all at once. Okay, so this is very common in CT and also in these urinary exams. So it's a large bolus given all at once versus drip infusion is going to be a large amount, but given within a longer period of time. So this is a drip infusion. These are your venipuncture supplies. Possible veins for venipuncture are the following: radial vein, median vein, median cubital vein, basilic, cephalic. Different types of needles that will be used: butterfly needles, over the needle catheter, straight through the needle catheter. Okay, the steps in hand washing, and this is something that you probably learned in patient care as well, right? So hand washing and gloves, right? How to apply the tourniquet, right? So the tourniquet should be applied 3 to 4 inches above the site of injection, which is usually in this area right here by the elbow. So you want to be 3 to 4 inches above the site. Palpate vein to confirm the site, then you clean the site, okay? And then you initiate puncture. So for the over the needle catheter, you're going to insert the needle always with the bevel up at a 20 to 45 degree angle, then you're going to slightly advance. This is with the butterfly needle. So butterfly needle in posterior aspect of hand, again, bevel up, and you would advance slightly. Then you want to confirm entry by observing flashback of blood, okay? And then you withdraw the needle and release the tourniquet. Tape catheter in place, you want to secure that needle, okay? And now we're ready for the injection. Okay. Okay, once we remove, okay, the needle or catheter, you're going to secure gauze with or cotton ball in place, keep it. So we usually will put a Band-Aid over it, right? And tell your patient to keep it approximately 20 minutes. Always wearing gloves, right? Always making sure that we're disposing of needles and syringes correctly in their designated sharps container. Okay, extravasation. And I think there is a slide on extravasation. Okay, so what extravasation is, it's leakage of iodinated contrast media when it goes outside of the blood vessel into the surrounding soft tissue. So it's also referred as to infiltration, right? So the vessel blows. That's another way you'll hear people call it in clinic. So the contrast leaks outside of the vessel. It's called infiltration. Contrast being infiltrated is bad. It's toxic to the skin and it's painful for the patient, okay? It will become swollen and red and inflamed. So this is not a good thing. You wanna, make sure that you let somebody know, okay? So you'll let the nurse know or the physician know, and this is what you're going to do. You're gonna elevate the affected arm above the heart, and you're going to use a cold compress first, followed by a warm compress. Okay, so first you use that cold compress to relieve pain, and then to improve reabsorption. Okay, so let's go back here. Okay. Again, elevate affected extremity, provide cold compress over site of injection for approximately 20 minutes, followed by warm compress. Okay. Urography and contrast media. So we're going to use, for urinary system exam, we're going to use water-soluble contrast media. Okay. We don't use barium like we do for upper or GI gastrointestinal exams. Okay. So it's going to be either ionic or non-ionic. We prefer to use non-ionic if possible. Okay, so ionic is going to have positive and negative ions. Okay, so non-ionic, there's going to be a less chance of reaction to contrast media. So they have the same amount of iodine. It's just that one is going to be less toxic than the other, okay? So non-ionic do not form separate ions, and ionic contrast media does, therefore causing a bigger chance of reaction, okay? So here, this chart is good to understand as well. So ionic, again, dissociates into separated ions, okay? Non-ionic, they do not dissociate, okay? With ionic contrast media, there's an increase in blood osmolality, okay? With non-ionic, there's no significant increase in osmolality, okay? So with non-ionic contrast media, it's gonna be very similar to the viscosity of blood and the thickness of blood. Therefore, there's less potential chance of a reaction versus ionic. There's an increase in blood osmolality causing a larger reaction, or more possible for there to be a reaction. So the miscibility is better with non-ionic versus ionic. It doesn't mix as well. Side effects, okay? So common side effects are going to be temporary hot flash, metallic taste in their mouth. That is a normal side effect, okay? It is very important that we ask for allergies, right? Anytime we're giving any type of contrast media, you want to ask for allergies. So this here is important with patient history. You want to make sure, we're going to check the creatinine levels and BUN. So we don't start the exam until we get these labs back. So it is important that you know the ranges for normal creatinine levels is going to be 0.6 to 1.5 megadeciliters. That's a number you should remember from now on. You're going to see this on the registry, under patient care, and under procedures. Okay, so creatinine levels 0.6 to 1.5, BUN levels 8 to 25 megadeciliters. Okay, 8 to 25 for BUN, 0.6 to 1.5 for creatinine levels. Now, you also want to check your patient's history to know if they're taking glucophage, okay, or also known as metformin. Okay, so you want to ask, are you currently taking glucophage or other medications for diabetes? So you want them to withhold metformin or glucophage 48 hours following the contrast media procedure. Why? Because contrast can affect how the kidneys will filter and clear out the drug from their body. Okay, so you want them to withhold, if possible, metformin after the exam. And then again, must verify normal kidney function. How do we do this? By getting the creatinine and blood and BUN labs. Okay, so there could be a pre-medication protocol at certain places. Usually, if your patient has an allergy to iodine, we definitely need to pre-medicate them. So Benadryl and prednisone over a period of 12 or more hours is a very common pre-medication procedure or protocol for this. Okay. Different types of reactions. We've already mentioned extravasation. That's it's considered a local reaction. Systemic reactions are going to affect the entire body or a specific organ system. Local reactions affect only a specific region of the body, like the arm during extravasations. Okay, we already talked about extravasation. Phlebitis is also a local reaction. So it's inflammation of the veins. So that's comes hand in hand with extravasation. These are the different reactions. So you have mild, moderate, severe. You also have probably seen this in patient care. Okay, you should have seen this in patient care. So you do need to identify mild, moderate, and severe reactions. You want to know the symptoms for each of these categories. You should be able to identify by looking at a list of symptoms, what category they pertain to. Is it mild? Is it moderate? Is it severe? Okay, and I believe this week's discussion is going to be, it asks about the different reactions, I believe, of contrast reactions. So make sure you review that. Clinical indications for for urinary exams. Well, indications and contraindications. So we're going to start with contraindications. So hypersensitivity to iodine, right? But we can pre-medicate the patient. That's not something that we have control over. That's something that the radiologist will determine. Another contraindication, anuria, multiple myeloma, renal disease, congestive heart failure, renal failure. So all of these are contraindications. And then these are some indications, okay? bladder calculi, okay, which are stones. And here we have some pathologies. So I'll let you guys review your pathologies. You will see some of these pathology images on your exams or your assignments. So make sure that you're able to identify these, okay? Hydronephrosis is going to be distension of the renal pelvis and calyces of the kidneys. Why? Because there's an obstruction in the ureter region, so it's going to be dilated in the renal pelvis area. Okay. So an IVU, intravenous urogram, these are not done very commonly anymore because of CT. Now, I will say recently I saw 2 of them being ordered, okay, at the clinic site that I go to. We actually had one ordered last week and then another one the week before. So I hadn't seen one of these in a really long time, and they just started ordering them again recently. And because they're not ordered too commonly, there are not very many techs that know how to do it. It's really the older senior techs that know how to perform these exams because they used to be done a lot more commonly. So some of the newer techs, they've never even seen it before. So that was their opportunity to go in and actually learn it for the first time. So as a student, if you get the opportunity to see one of these, observe one of these, or you hear that there's one coming, make sure that you sign up for it, that you say, I want to be in the room observing, so that you're able to see one before you become a tech, okay? So we want to do this exam. It's an exam of the urinary system. So we're going to visualize the collecting portion of the urinary system, as well as assess the functional ability of the kidney. So it's twofold, okay? And it is a time procedure. These are some indications, okay? Make sure you review them. Preparation. Okay, so light evening meal prior to the procedure, bowel cleansing laxative, okay? We do want to make sure that everything in the abdominal area is clear of fecal matter, okay? Because it's going to be obstructing our field of view. NPO after midnight, minimum of 8 hours, and then an enema the morning of the exam as well. And you want to have your patient void before the exam. Okay, you will see some questions about uretic compression. Okay, so uretic compression is a method of enhanced filling of the pelvical seal system. Okay, so it's going to help for the contrast media to remain longer in that area, in the pelvical seal area. Okay, so that's right in the kidney region, right? Okay, so we want to we want the contrast media to stay in that area for a longer period of time so that we get better images. Okay, and this is the method that we use. It's called uretic compression. Okay, ureteric compression placement and the 6 contraindications. You need to know these 6 contraindications, or you should be able to identify some of these, okay? So this image here is showing you where to place the paddles for ureteric compression, okay? They go medial to the ASIS, okay? ASIS is here, and they're going to go medial, just medial to the ASISs, okay? What are the 6 contraindications for using ureteric compression? Possible ureteric stones, abdominal mass, abdominal aortic aneurysm, so AAA, recent abdominal surgery, severe abdominal pain, and acute abdominal trauma. You will not use ureteric compression if your patient has one of these 6 contraindications. If they do, then we have this alternative method, which is the Trendelenburg position, right? Gravity is going to help it to remain longer in that region. Okay. All right, so this is the routine, the normal routine for a basic intravenous urogram, okay? So your patient, you will inject the contrast media. It's very important, it's very time sensitive, okay? So the injection usually takes between 30 and 60 seconds and 1 minute to complete, okay? Inject the contrast media, making sure that you are watching your patient, making sure that they're not having an allergic reaction. You want to note the time at the beginning of the injection, okay? Then we're going to do a 1 minute, which is called a nephrogram or nephrotomogram. That's what that 1 minute image is called, okay? Then we do a 5 minute, a 10 to 15 minute, and then a 20 minute posterior obliques and a post void. Now the routine or protocol can vary at different facilities. Okay, so it's important that, but that's more or less how it's usually going to be. Now we're going to talk about the nephrotomogram, which is really important. Again, that's the 1 minute radiograph. So what do we do? What are we assessing on this 1 minute nephrotomogram? So it's going to demonstrate the renal parenchyma, okay, which is this, what we're viewing, this nice blushing here, the renal parenchyma, or which is also the functional portion of the kidney. Okay, so a nephrotomogram or nephrogram demonstrates conditions of and trauma to the renal parenchyma. This is exactly what we're trying to see. Okay, so timing is critical. Okay, we do it at 1 minute. Okay. So this is what a nephrotomogram is, okay? So not all equipment has this ability, okay? Which we are going to talk more about this next week, okay? So a nephrogram or nephrotomogram. Nephrogram you would do if it doesn't have this ability, the machine, and it would be called just a nephrogram if we didn't have this. It would be still a nephrogram at 1 minute, but if your equipment has this ability to do this, then it would be called a nephrotomogram, okay? Let's see here. So what this is doing, you guys, and I don't want to focus too much on this because we're going to talk about this next week. But what this is going to do to get a better view of the kidneys here, what it's going to do is blur everything above and below the kidneys, okay? So that it's going to blur out the ribs and any other overlying anatomy within the kidney region. So it's going to blur everything above and below the kidneys, this effect. So it goes back and then it goes forward, okay? And the IR is going to follow, okay? But we're going to talk more about the actual tomographic exposures next week. Then we have what a hypertensive IVU is. So it's just like an IVU, but this is done for patients with high blood pressure to determine whether the kidneys are the cause of the high blood pressure. And it requires a shorter time between projections in comparison to the regular IVU. And this is the suggested protocol. Okay, then we have another exam. We're moving on to another exam. This is called a retrograde urogram. So it's performed in surgery. It's called retrograde because it's going retro. So it's going in the opposite direction, right? So contrast media is delivered retrograde through the catheter. Okay, and this is what it looks like. So it's going in through the urethra into the bladder, and we would inject, so it's going upward versus downward. So it's retrograde. Okay, then we have a cystogram, which is also retrograde. So this is to visualize the bladder, okay? And we have what's called a voiding cystogram, and then just a a regular cystogram, okay? So contrast media is going to be introduced through the catheter into the bladder. So gravity flow of contrast media will be about 150 to 550, I'm sorry, 150 to 500 milliliters, okay? And we just do some, and here you can see the contrast media, okay? And it's connected to a catheter going into her bladder. Okay, we do have what's called a voiding cystourethrogram. So once we've injected the contrast media into the bladder, we want to watch the patient void under fluoroscopy to make sure that everything is going out correctly, to make sure that everything is flowing out properly and that we don't see any reflux going back up into the kidneys, which can be the cause of a urinary tract infection. Okay, so a lot of the times when you watch, and this is a very common exam in children, okay, in girls, okay, in little girls. So when you're doing the voiding cystourethrogram, you'll watch the patient void, and sometimes you'll see that when they're voiding, the contrast media is going back up. It's refluxing into the ureters and then potentially into the kidneys, causing infection. So that is the purpose of watching them void under fluoro. And this is how we watch. So on females, we watch them void AAP with their legs spread apart. In men, we watch them void in an RPO so we can have a better view of the urethra. Then we have a retrograde urethrogram, which we call them, in short, we call them RUGs, R-U-G. And this is an exam only for males, okay? And this is only to view the urethra. We want to make sure, let's say a patient comes in a car accident or a motorcycle accident, and a lot of the times their pelvis gets broken, right? There's injury to the pelvic region. So a lot of the times it can cause for the urethra to be punctured, okay? So they want to make sure that the urethra is intact. So it's called a retrograde urethrogram, so a RUG. And so what we do is inject or insert a catheter to just maybe about an inch or half an inch into the urethra, okay? And then we inject contrast media to make sure that we can see the urethra flowing all the way through. There's no leakage, and that it goes into the bladder. Your patient will be in a 30-degree oblique while we do this. Now, this is a Brodny clamp. This is not commonly used anymore. It looks like a torture device, if you ask me, especially for males, can be really intimidating. You can see the little tips here, the clamps, which will be, clamping onto the soft tissue of the penis. Okay, so it's not commonly done anymore, and so it would go. This part would go into the opening of the urethra, and then we would inject contrast through this. But now what we do is just use a catheter. Okay. So now I guess we're going to go into the actual positioning of the IVU. So it's a KUB, right? Center at the level of the iliac crest, include pubic symphysis, no rotation. Okay. This is a 10-minute. For the nephrogram, okay, you're going to center midway between the xiphoid process and the iliac crest. Why? Because that is where the kidneys are located generally, right? Somewhere between the xiphoid process and the iliac crest. So the entire renal parenchyma should be visualized, okay? And that's what we are looking at. And notice that it's labeled 1 minute. Then we do some obliques, RPOs, LPOs at 30 degrees. Now, this is a very important slide right here, okay? So you do RPO and LPO, okay? Because on the RPO, you're going to visualize the downside ureter, so the right ureter and the left kidney. When we do the LPO, we're going to be visualizing the left ureter and the right kidney. Okay, remember I mentioned that the kidneys are located backwards at a 30-degree backward angle towards the spine. So in order to get that kidney parallel to the image receptor to get a true AP, we need to rotate the patient 30 degrees, okay? So the elevated side is the side that will demonstrate the kidney. The downside will best demonstrate the ureter because it's gonna be free of superimposition of the spine, okay? When you rotate, you're gonna be able, the downside's gonna visualize the ureter, okay? And it's gonna visualize the upside kidney. That's very important to know. Okay, you'll see that on an exam, you'll see that on the registry. Okay, so for IVUs, your RPO, your obliques, is important that you know what's best visualized on the RPO, what's best visualized on the LPO. Remember, downside ureter, upside kidney. And then we do a post void. Okay, so we have our patient go to the restroom, void, and then we take an AP or PA, depending on the facility's protocol, and usually it is erect. And we mark it post void, okay? And you can see that there's not a lot of contrast media in the urinary system anymore. You see a little bit left in the bladder. We talked about the uretic compressions. Okay, make sure that you know your 6 contraindications. Okay, and so here we have an AP 5-minute with the ureteric compressions, and you can see that the pelvical seal and proximal ureters are nicely filled, okay, with that uretic compression. Cystograms, remember, cystograms are to view the bladder. Therefore, we're going to center essentially like a pelvis. Where do we center for a pelvis? 2 inches superior to the pubic symphysis. Okay, so that's where the bladder is located. We can also do a lateral, but usually it's just APs and obliques, okay, because the laterals, it is a lot of radiation. So here we see the AP, nicely centered pelvis. You see the entire bladder, and then here we have an oblique. For the voiding cystourethrogram, same thing, you guys, okay? AP for females with the legs extended, separated, and for the male, we're gonna oblique 30 degrees. We're gonna do a 30-degree RPO to superimpose the urethra over the right thigh. Okay, we want to watch our patients void in this position. Okay,